morning, everyone. Welcome to the Breakfast Health series today. We have two very interesting topics. Due to the use of time, because we have four speakers. I will first introduce the first sessions, which is TIPS. TIPS is a transjugular intraportal hepatic shunt, and this talk will be presented by two speakers. One is by Dr. Choong, who is an intervention radiologist, who will discuss more about the technique and the procedure, and Dr. Shahridan, who is a consultant gastroenterologist, who will be discussing about which are the patient selection criteria. Okay, without further ado, let's welcome Dr. Eric Choong.
Okay, so basically TIPS, it's well, this procedure is actually a multidisciplinary management. So actually, before I describe my everything from my side, I would like to pass the floor to Dr. Shahridan. Let her explain to you very quickly indication, all this from their team first, from the referring team. Can I please invite Dr. Shahridan, please? Thank you.
Hi, good morning, everyone. Thanks, William. Thanks, Eric. So I'll try to go as fast as I can about it. Let me see. So we're going to be talking about tips. And first of all, good morning and Assalamualaikum, and thank you for giving us the opportunity to speak today. So the theme, actually, I think for our presentation is the fact that teamwork makes the dream work. And that dream was for us to do tips. So what basically is TIPS? It's actually a shunt created between the inflow portal vein and the outflow hepatic vein that actually reduces portal venous pressure. It was first used in a human patient in Canada in 1982, but it was only first successfully done in 1988 in Germany. So this is just a bit of our case presentation. We had a patient 48 years old with alcoholic liver cirrhosis, had recurrent presentation of torrential gastric variceal bleeding. So 4 times within 6 months, presented again with hematemesis, tachycardia. So what we did, we went in for a scope, and we know there was a bleeding gastric varices. This is the actual scope picture from that endoscopy. We injected hysteroaquil, and then hemostasis was achieved. So subsequently, we actually decided for preemptive TIPS. Now, I'll describe to you later on what does that mean. So, and TIPS was actually successfully done about 10 hours later. So this is our TIPS team. It's not the whole team. It's just a few of us who were there on that day. So it's a multidisciplinary team. And I'm happy to report that we did our first locally accessible TIPS in UMMC on 1st March 2025. And here I would like to give a huge shout out to Eric. So this was actually, Eric spearheading us, his dream, his idea. And Eric did a fellowship in TIPS, and he brought that skill and experience back home to Malaysia. I did a fellowship, not in TIPS, but in something else. But in Melbourne, where I was, they did a high volume number of TIPS. So I learned along the way. And Eric, before he came back, had asked, let's start the TIPS service. So a huge credit to him and the IR team. So what is actually the role of the gastroenterologist in TIPS? So we need to know the indications for TIPS itself, and then for pre-TIPS assessment and patient selection, the procedural details, the post-procedure care, and the long-term follow-up. So what are the more common indications of TIPS? So one is variceal bleeding, and this is whether it's done as salvage or emergency. Preemptive TIPS, which actually means that when in the context of our patient, the early TIPS insertion within 72 hours of variceal bleeding managed with endoscopic treatment and vasoactive drugs, and then we decided to go and proceed with the TIPS. And then also electively, so electively mean for secondary prevention of either esophageal variceal bleeding or gastric variceal bleeding. So another common indication for us to do TIPS is actually for ascites and hepatic hydrothorax. So TIPS for diuretic refractory ascites. So recent meta-analysis actually already looked at the role of TIPS for diuretic refractory ascites, and it has already been shown that it improves ascites control and survival. However, what we worry about in this kind of situation is the risk of hepatic NCAF. So other indications, but probably less common first, TIPS for Budd-Chiari syndrome. But carries actually an obstructing hepatic venous outflow from the liver of the sinusoids to the IVC. So we're actually at the moment currently working up a patient with bicarious syndrome for TIPS. So, and probably least likely indication for TIPS in our country, but which is more common in the more developed countries, are TIPS prior to non-hepatic surgery in patients with portal hypertension, because it has been shown that patients who underwent non-hepatic surgery actually has a risk of hepatic decompensation. So they sometimes consider doing TIPS prior to that. So what is important is also to do a pre-TIPS assessment, and how do we select our patients? So the comprehensiveness of pre-TIPS assessment actually depends on in what type of or what situation we want to do the TIPS, and also what are the indications. So whether we want to do as we decide to do as emergency or preemptive or elective. So among the things that we have to consider are the complications, and among the more common complication is hepatic NCAF. So the incidence of post-TIPS hepatic NCAF has actually been reported to exceed about 50% in some cases. And patients that have a higher risk of post-TIPS hepatic NCAF actually include patients who are older, has more severe underlying liver disease, has a history of previous hepatic NCAF, diameter of the TIPS shine, and presence of diabetes. So patients with who are undergoing elective TIPS actually go more is actually recommended to undergo a more thorough assessment of hepatic NCAF. So and for example, assessments such as EEG, but for salvage or preemptive TIPS, you may not actually be necessary to do so. So another thing is also vital cardiac assessment, as we know. So patients with liver cirrhosis, the most common cause of death is actually cardiac cause. So what happens in TIPS is that after TIPS insertion, it actually causes a significant increase of venous return to the right heart, which then causes increase in cardiac output and right atrial pressure, and therefore can lead or precipitate heart failure. So all patients ideally should be investigated with a thorough cardiac history, physical examination, ECG, proBNP, and also an echocardiogram. Also important is for us to consider liver dysfunction. So the MELD and Charles-Butte scoring should be assessed. So patients with elective TIPS, we probably may exclude patients who are high risk, such as patients with a MELD score about more than 15. Ideally, the patients should also have a nutritional assessment. So sarcopenia prior to TIPS insertion has actually been associated with development of post-TIPS hepatic NCAF. So sarcopenia pre and post-TIPS has been associated with reduced effectiveness of TIPS and higher risk of liver failure. So ideally, nutrition should be optimized prior to considering TIPS insertion. So in terms of renal function, so patients with CKD stage 4 and 5, we do not recommend for TIPS. So as it increases post-TIPS mortality, and there is a very much higher risk of hepatic NCAF. And last but certainly not least is whether the patient anatomy is actually feasible for us to do TIPS. So, and we assess this by actually doing a CT liver 5-phase, and Eric also likes to do on top of that an ultrasound to assess the anatomy. So this is just a summary of things that we should consider prior to TIPS insertion. So that thing is the procedure details itself. So of course, when we decide for TIPS, it's a multidisciplinary discussion. It's not a one-person decision. So there should be a good discussion between IR and also with the gastroenterologist, hepatologist. And of course, consent should be taken, informed consent prior to the procedure. And when we take the consent, we should also explain the indication, the alternatives, the risk of post-TIPS hepatic NCAF, the morbidity risk, and also the procedure-related death risk. And also when we do the procedure, the sedation, we want the patient to be comfortable, and to minimize the risk as much as possible. So we also get our NS colleague support, and TIPS are generally inserted under GA. So for patients who are doing TIPS for ascites, ideally we admit them about 2 days before so that we could actually drain the large volume ascites. In terms of antibiotics, actually routine antibiotic prophylaxis is not recommended. So for blood products, so ideally our patients, the fibrinogen should be maintained more than 1.2 and platelets more than 50. So for post-procedure care, so what happens after the procedure? So it's actually quite common for the patients to actually complain right upper quadrant discomfort, and this can be treated with simple analgesia. So if patients actually complain of severe pain, and this is associated with hemodynamic compromise, then this should trigger a more thorough evaluation and more imaging. So in terms of the tips itself, so we actually do an early Doppler ultrasound and prior to discharge to ensure the tips patency. And this at my previous center, we would do this at day 3. So in terms of long-term follow-up, so routine imaging of tips is actually not required, but all liver cirrhotic patients actually do undergo HCC surveillance anyways, so by every 6 months. So, but when you suspect that there is a TIPS dysfunction, and this means that there's still persistent recurrent ascites, so there's still persistent recurrent vessel bleeding. So this should actually trigger us to evaluate further whether there's any TIPS dysfunction in terms of whether there's possible thrombosis or increased velocity. And this can be initially investigated with Doppler ultrasound. So I'm happy to report to that patient that we had presented earlier. So this is her. We had seen her about 1 month after that too. And she is doing very well. And I would like to acknowledge Eric, for spearheading the TIPS service. We're very fortunate to have you. And also the IR team. Dr. Keith, who's our hepatology fellow, is also part of the TIPS team. And here I would also like to acknowledge my fellow colleagues and senior consultants in St. Vincent's, Melbourne, who actually guided me a lot in terms of, to start the TIPS service. So also thank you to the gastro and hepatology unit here. And also thank you to our NS and cardiology team who helped us to assess our patients and optimize our patients prior to the procedure. So I would like to hand out to Eric to speak more about the procedure itself. Thank you, Eric.
Thank you, Sheridan. Yeah, you came in just on right on the spot, 13 minutes. Very good. So right, okay. I just answer the question while it comes. So how long does TIPS last in the system? Does it need to be removed? No, it's actually quite permanent. I mean, we do this patient usually we put in TIPS. They are kind of like the intermediary to transplant. But as you know, in Malaysia, transplants not very common. So not readily available. So most of them will last a lifetime, and eventually they'll get blocked, which needs re-intervention. So yeah, which is what I'm going to talk about in just really quickly. All right. So, all right. So whoops, already thank you. Ooh, let's go back. Okay, so I stole this slide from, I just modified a bit from Sheridan's one. So basically, the first same slide, but a bit different. So basically, she already told you about what TIPS is all about, but you might not be able to imagine it. So now I'll put that imagination, turn that imagination into somewhat of visual picture for you. So that's a shunt that's created between portal vein and hepatic vein. The problem is the portal vein pressure is high, so that will cause us malformation of a vessel in the gastric varices and stuff like that, causes bleed, causes ascites and hydrothorax and what's not. So these are the indication to reduce the pressure. So that's the aim. We want to have a gradient between the portal system and the systemic venous system of less than 12 mmHg. Okay, so basically, usually we shunt the right hepatic vein to the right portal vein, or right portal vein to the right hepatic vein. But actually, it doesn't matter. You can shunt any vein to any portal vein to any hepatic vein. But the technique traditionally was described like that. So the procedure failure actually in Malaysia is very, very high. We actually attempted a few years ago, and we have failed to do this because traditionally it is a bit difficult. I'll tell you why. Some of the other reason is because technical technical reason, operator experience, difficult anatomy, which is small or thrombosed portal vein or small hepatic vein, diffuse ascites. Sometimes we don't have the equipment. Like last time, the needle for us to do the tips wasn't available in Malaysia. We have to sneak one from Singapore. And of course, with anything in actually UMMC, is the cost is an issue because patients do have to pay for consumable. And back then, coward plus bare stand with transjugular set, that's 30K, and with no guarantee of success. Yeah. So once we open the set, that's it. Your 15,000 is gone at least. Okay. If we didn't deploy the stand, your 15K is already gone. But we have managed to, I've managed to kind of bring down the cost now. So if you do covered stand plus a bare stand with transhepatic access, which what I've learned in Hong Kong, that's going to be 20K. And if I just put in a bare stand and transhepatic access with transhepatic access, that's 10K. So that's already very affordable. And if we don't get the access, I think you lose 2K or something like that. It's very, very little. So it's no longer that expensive if we do it with what I've learned in Hong Kong. So what do you mean by the traditional technique? So the expensive thing is the needle from the jugular vein. So that's what we approach from the top. And then, we approach that, we go to the right hepatic vein. And then what we do is we put the needle in and we hope that the needle will puncture the portal vein. It looks easier than it looks easier than you see, but actually it's very hard. So we measure the portal vein pressure first. Then after that, we take the needle. We kind of blindly agak-agak angle the needle and we try to puncture this portal vein. This is the hardest part, basically. If the anatomy is weird and the portal vein is small, it's like hitting the needle in the haystack, isn't it? So this is what you do. After that, once you get the access, you put the wire in, and then you dilate with the balloon. Okay, you put you dilate this track. Okay, once the track is established, okay, you put the balloon in. Once the track is established, you start it. Okay, so then you create that track. So that's a permanent track, and then you have to look after this track that you created lah. Okay, because usually there will have some complication, but it depends. Okay, so that's how it's done. Okay, so this is this is a technique that I use. I use it. Instead of approaching from the jugular, I approach from the transhepatic side. So we use ultrasound and we kind of saute. I try to saute the portal vein and the hepatic vein together first before I put in the thing, and the rest is the same. Okay, this is a paper described in 2012, actually very, very early on, but it's not really practiced elsewhere in the world. So this is done in Hong Kong lah, but Simon Yu is from Hong Kong. So what you do is actually look at the ultrasound, which is why Sheridan said Eric's want an ultrasound. Why we want actually I'm trying to find this plane, because if I can't find this plane, I can't do it. Okay, so basically what you do is you look at this hepatic vein. You can see the hepatic vein here at the below, which is B, and A is the portal vein. You see the portal vein and hepatic vein on the same plane. You put a needle through both of them. Okay, and then you kind of create a artificial shunt, reverse of what you see from the from the hepatic vein to portal vein lah. Okay, so so after that you put you put the thing up, and then you snare the wire up from the jugular vein, and you approach from the jugular vein as per normal, and you put in the balloon and everything as normal, except that you have another wire here, which is the safety wire. Okay, so after that, you stand as usual, and then you remove the safety wire, and then you can see sometimes we depends on the patient. If the patient has a lot of varices, we can actually put a few coils to slow down and divert this blood from the varices into the shunt. Okay, it's up to we will discuss them with the gastroenterologist before we proceed with these things. But all these are extra costs, unfortunately. So So in Hong Kong, a lot of times we put in a bare stand only. Here, actually, in tips, we need to use what we call Viator, which is a custom-made covered stand plus bare stand. So the one that is protruding into the hepatic vein is a bare stand, and the one involving the tract is a covered stand. So why? Because they found out that actually because you are creating a shunt in the intraparenchymal hepatic parenchyma, there's bile leakage into the system. But so the rate of complication, if you see here, in 2 years, shunt dysfunction actually was 44 versus 63. So 44 for cover stand, and 63 for bare stand. So 63% in 2 years. So 20% higher. But if you talk about the cost, you have to take cost into consideration as well. So if the patient have symptoms, does it mean that if he can't afford 20K, but he can afford 10K, will you not do it because it's 20% higher dysfunction rate in 2 years? Absolutely not. I think you should just go ahead because you can still re-intervene later on. Okay, so this is another study in 2016. Also show somewhat 20% higher when you compare bare stand with covered stand. So yes, covered stand much better, 20% better. But does it mean that you don't treat the patient who can't afford it? I think not. I think you should go ahead and just do it. Okay. So that's all for me. Any question from the floor? I will take. I think Wei Lin is kind of stuck in the internet. Okay, I think I got a question here. What is the total cost? There you go. I think I have answered this. I don't know. Is it Sharida? Is it covered by JPA? Yeah.
Yeah, so it is because similar to your IR procedures in which that they are able to claim in terms of the stents and everything is something that we are also attempting, but the duration of when the claim will be improved, that's something that we cannot determine.
Yeah, so usually the issue with JPA is the time it needs to get approved, and that sometimes it's emergency tips, and you have portal vein thrombosis that's create high pressure in the portal system. Then you need to kind of we call it rescue tip. We want to rescue the patient from rebleeding. That warrants an emergency intervention. Those I don't think can wait for JPA, to be honest. But as with anything that we started, things can be improved later.
Just also want to highlight that actually Eric had managed to bring down the cost very significantly. Like before this, if we wanted to attempt it, it was at least about 30,000 ringgit. And, those previous attempts actually was not successful. But Eric, had brought the skill and of his experience back and managed to cut down the cost by about 50, like more than 50% actually. And he's been doing pretty well.
Okay, so the
There are a
question.
few more questions.
Okay, there you go. Yeah.
Yeah, there's a question from Ban Hong. What do you do it if there's recurrent encephalopathy? What do we do if the patient has encephalopathy after tips?
So that is a good question, and that's actually one of the things that we often face, even during my time in Melbourne. So ideally, prior to the procedure, you try to optimize it. So there's been some studies looking at lactulose and also rifaximin as a primary prophylaxis. So there was a big French study in 2021 that actually St. Vincent's do also apply, in which they initiated and then they keep the rifaximin lactulose about 6 months even after the procedure. So how about when hepatic encephalopathy actually happens after the procedure? So again, we manage hepatic encephalopathy like how we would normally manage. So in terms of dealing with the constipation, giving lactulose, I can also give rifaximin, can refer to a dietitian for amylolabin diet. So, but in terms of procedure-wise, there's actually things that from the procedure-wise that we could overcome this. And this is depending on the diameter of the tip stent size. So, and what they would recommend is for you to actually reduce the tips diameter size. So studies have actually shown that an 8 millimeter tips diameter stent actually has been shown to have less risk of hepatic encephalopathy than a larger one. Eric, your thoughts on this?
Yeah, so usually if we will try to reduce it either by deploying another smaller stand in it, or actually if it's very bad, we completely we reverse the shunt by embolizing it. Unfortunately, yeah. Is that way? Wei Lin, you want another question here from Jason? Patient selection
Jason
criteria.
asked the conventional tips. So, for the audience, there are two ways of doing. Traditionally, we go through the jugular vein, and this one is transhepatic. And I think both techniques are doable. But Eric, you want to explain? Is there any difference?
Yes. Okay. So basically, when you select your patient in conventional, you do a CT5 phase, and then you see the sizes of portal vein, the position of portal vein and hepatic vein in relation to each other. If it's not too close, it's too far, some of these vessels are too small, then you say, oh, this is gonna be difficult. I don't think it's worth doing it, and then you say, okay, so usually in conventional, you look for the right hepatic and the right portal vein. But for this technique, if you're doing transhepatic, you look for any plane that cross between hepatic vein and portal vein, and that can be easier said than done. But it no longer limits you into this right hepatic vein, right portal vein. In fact, the last one is when it went to the accessory hepatic vein, which is okay as well. So as long as you be able to put in, you be able to connect these two systems together with a needle via transhepatic approach, you are golden. So there's a lot of cases where you think that you might not be able to do conventional, you can do with this technique, which is more skill-based rather than a lot of times agak-agak based lah, where you look at the, I think it's at 7 o'clock and then I put in the needle and hopefully when I inject contrast, there is portal vein opacification, is much better chances of getting it right with this technique. Thank you.
Yeah, I like to add that all patients are different, and then we need to really select the patient and like do it. So, Eric, if there's any failure, what's the failure rate of tips if you
So
can't
far,
get?
the one we've done actually is quite good. Why? Because like Sharidan said, Eric likes to do ultrasound addition, which they don't do anywhere else. Because when patient come down ultrasound, you're already looking for that plane. Once you found that plane, you say, okay, this one you can do workup. Because you find the plane that you are comfortable first. When the patient comes down, you say, oh, there is a plane. Then you can do it already because there is one. So when you're working out the patient, you just do an ultrasound and you already plan your approach from there. You find the portal vein, you find the hepatic vein, and if you can see them at the same plane, you're golden. The patient is a go for tips.
Yeah, I think we take one last question before we wrap up our session. What percentage of varicose bleed is seen after tips? This is for Sharina.
Thank you. That's good question. And actually the percentage kind of varies, but I just want to highlight here because I just want to let everyone know that even after we do tips, the first 3 to 6 months, actually it takes about like 3 to 6 months to achieve kind of like an equilibrium state. Okay, so during those first 3 to 6 months, you may expect that the patients would still have, if you do it for ascites, to still have ascites, you may still have to tap, or if patients have vessel bleed, would still have to go for banding echo injection. So from our experience, the first 3 to 6 months, it does take for them to achieve this kind of equilibrium state. So you do anticipate that. But after that, after achieving the equilibrium, and some centers actually we measure again what is the pressure gradient, but we didn't unless it was for like trial or study purposes. The risk for them to get another episode of varicose bleed is very, very low. It does happen. Some studies actually show that it may happen slightly more common. The percentage rate might be a bit more higher, about 20 to 30%. But in most situations, after you achieve that equivalent state, and if you actually achieve that target pressure gradient, like less than 12, then the risk of it to develop is low.
Okay, thank you both Dr. Eric and Dr. Shaidan. I think due to the interest of time, we would like to pass on to the next session to Prof. Nazirah. And I just want anyone to know that we intervention radiologists is a really minimally invasive procedure that really can help patients. So anything you can welcome to discuss with us, and I'll discuss cases for tips during the MTT. Okay, thank you everyone. Next,
Thank you. We
to
finished
Prof.
on
Nazirah.
time. Right on the dot, 30. Haha.
Told you,
Okay.
Eric. Thank you.
Well done.